Vamsi, can you try sharing the PowerPoint, Kana? Kana sir, good evening, sir.
Sir, good evening, sir.
Good evening, sir. Karnakaran sir, good evening, sir.
Good evening, sir.
Okay, friends, good evening, everyone. Welcome to the PG Clinics for this Friday. We have eminent faculty, Professor Puneet sir from Institute of Medical Sciences, Banaras Hindu University, and Professor Karan Rawat is in from SN Medical College, Agra, is expected to join. We have Professor Manjunath sir from BM Patil, Bijapur. Thank you, sir, for joining and kindly permitting your PG to present a case here. I hope Professor Saravanan sir will be shortly joining. And we have our faculty, Kanna sir, Jailal sir, Karnakaran sir. I think Hitesh Andare sir and Srinivasan sir have excused today to join. Rajiv sir is already here. So we have two important cases. Actually, they are kindly contributed from two different institutions. One is from Guntur Medical College. Ramani madam has kindly contributed. And we have other candidate from BM Patil Medical College. Actually, madam has been given this candidate 2 weeks before itself, but then we wanted one after the other. That's the reason we had to wait. So I thank both the faculty for permitting the PGs to present the case. So I would request Dr. Pandey to first share his PowerPoint and start his presentation. Faculty, please take over.
Good evening,
Pandey?
staff.
Yep. Good luck to you, Ma. Please introduce
you,
yourself, your unit chief, your HOD, and then start your presentation.
Good evening, everyone. Myself, Chetan. I'm a third-year junior resident of general surgery from Sri BM Patil Medical College, and I'm presenting this today case presentation under the guidance of our unit head, Dr. Vijay Patil Madam, and our head HOD, that is Dr. MB Patil sir, and under the guidance of also Madam Tejaswini Madam and Manjunath Kottanar sir. Good evening, everyone.
Make it full screen, Ma. Kanna sir, good evening, sir.
Good evening, good evening.
Good evening. Please start, Dr. Chetan. You're good to go.
Thank you, sir. So I'm here presenting a case of 70-year-old male who is a farmer who comes from Tikota, Vijaypura, with a chief complaint of swelling in front of the left chest since 8 months, and also complaint of discharge from the swelling since 2 months. A patient was apparently normal 8 months back, following which he noticed a swelling in front of chest wall, which was incidence onset and gradually progressive in nature from of around 2x2 size to attempt the present size of 12x7 centimeter, which was associated with pain since 2 months, which is dull aching in nature, low in intensity, non-radiating, and which reduces on medication. He also gives a history of discharge from the swelling, which is watery in nature and around about 10 to 15 ml per day in quantity, which is non-foul smelling. Patient has a history of loss of appetite. There is no history of fever, no history of any trauma, no history of any backache, no history of any cough, hemoptysis, breathless, or no history of any pain abdomen, abdominal distension, yellowish discoloration of eye, no history of weight loss, and there is no history of any other swelling in the axilla. Coming to past history, there is no history of any similar complaints in the past. And he was a known case of pulmonary tuberculosis 4 years ago, for which he has completed anti-tubercular treatment, which he has completed for 6 months course. And he was declared to be tubercular free following the course. And he has no history of any hypertensive diabetes or asthma. Coming to personal history, his diet is mixed, appetite is reduced, and sleep is undisturbed. Bowel and bladder habits are normal and regular. And coming to family history, there is no history of any similar complaints in males or female of his family. Sir, I would like to summarize with the history, sir. Here is a 70-year-old male who presents with complaints of swelling in the left anterior in front of chest and discharge from the swelling since 8 months, and who has no history of any who has no family history of any similar complaints, who is a known case of tuberculosis, who has completed his regimen and is declared as tuberculosis free.
Why do you say it is front of the chest wall? What is the meaning of front of the chest wall?
Sir, basically in front of the anterior part of the chest, sir.
No, it is in the chest wall or in front of the chest wall?
In front of the chest wall, sir.
No, in front means it is not attached to that.
Yes, sir.
It is in the chest wall.
You can mention it, Chetan, over the chest wall, left side chest wall, isn't it?
Rather than saying in front, you just say they're swelling over the chest wall, isn't it?
In the chest wall is the best way, not to use the front and enemy. There's no word like that in our anatomy.
Okay.
No, but end of the history, we are not able to. I mean, what is the possibility you are thinking that?
Sir, it was a swelling which was started, sir. Also discharge.
Provisional diagnosis.
Since when has the discharge been coming and the nature of discharge?
So the discharge is there from since 2 months, sir, which is watery in consistency, sir.
Any smell? Any odor?
No, sir, it's a non-fouling smell, sir.
So all this has to come. We want to know what kind of discharge. Is it pus? That's what we want to know, whether it's pus or something.
Chetan,
No, sir.
can you explain water coming from the swelling? Any condition you know where the water will come. Water is a colorless.
Water, yes.
It can be either a serous discharge or serosanguinous discharge.
Okay, answer sir's question. Tell us a condition when there is watery discharge from the skin.
Chetan, just I want to emphasize the same thing Dr. Jalal was saying, that there must be an ulceration which has happened due to the swelling which has been from the discharge there from the area. So it is important.
Dr. Prajwal, please mute yourself.
Class attend kammannadu
Sorry.
Yeah. Okay. Chetan,
Sir.
Can you tell me a condition in which there is watery discharge from the skin?
So watery discharge, basically it can be sweat, sir.
That's fine.
That's
That's not a
can
discharge.
come.
That's not a discharge.
Need not be not with the chest, at least in the somewhere in the midline of the abdomen.
Yes, somewhere else. Have you heard of lymphoria?
Yes, sir.
You get watery discharge from the scrotum if there is a lot of.
Edema, yes.
Okay. Yeah, please, sir. So there's just swelling and discharge. That's it. Nothing
Yes,
else.
sir. Nothing else, sir. With the history.
Swelling from where, Chetan? Swelling arising from where?
Sir, he gives a arising from the chest, sir, over the chest, sir.
Chest is a very wide area. It has a large area. Whether you are going
Is it
to
from
say
the nipple areola? Is it from the axilla? Is it from where? What side?
From the nipple areolar complex, sir. It is extending
what
in.
is the difficulty in saying that? It is
So
arising
just
from
say
the
that
nipple area.
from the left nipple areola of the breast. Just say that.
That
I
will
mean-
be more ideal than saying beating around the bush. You are
Yes,
postgraduate.
Very
Postgraduate need not go
enigmatic here.
around.
Very enigmatic. You say just say it's just one. Just say nipple. You got a reference, no? Nipple area. So swelling of the right. So now we've got a working, we can come to something. Now, what do you think it is? The 70-year-old man swelling in the nipple areola with some discharge.
Sir, with the male, and I would like to think of more towards any breast condition, sir.
Yes,
Mainly
definitely. Definitely.
As the nipple is involved, I would like to more consider of a Paget's disease, sir.
We can't come with history. Can't come to diagnosis of Paget's. Please don't stretch it to that much. We give you a rope that you can come to a diagnosis of breast malignancy, but it all can't stretch it.
This is very, very rare. It's not reported much from the male breast. It is not a common for a male breast to have a Paget's disease.
When the patient came to you with the discharge from the dimple area complex, did you look at the picture, or you have taken a picture or a video?
Yes, sir. I have a picture, sir.
Yeah. Do you have a video of the discharge? When does it come? What time does it come? Does it come often? What is the type of discharge? Is it coming from a single duct? All these things, did you say?
Sir, I'm sorry, sir. I don't have a video, but sir, patient apparently gives a history that there is a continuous dripping kind of discharge, sir, which is around.
From the areola or nipple means single duct or multiple duct?
Single, sir. There's a single from the single opening, sir. Around heat cells around a half a handkerchief of.
It's not opening. Is it in the ductal discharge or is it separate opening? They've got some discharge difference, isn't it, Chetan?
Yes.
Chetan, just I want to emphasize the same thing what the other you can say examiners want to know, whether there is any ulceration, fissure, eczema which is present there, which is causing any discharge there. You must have to spell out. See, a lump can't give a discharge as such unless until there is a breach in the epithelium, or there is a vesicles there is a lymphoria. So unless until there is a breach in the epithelium, there won't be any discharge as such, excepting few conditions. So whenever you talk about the discharge, there must be any ulcerations, fissures, eczema which is present there, which may be causing discharge. So you have to spell out that everyone want to know. Is it clear? And next, whether it is there from the nipple, then of course you have to comment about whether it is there from the nipple. Then you have to say it is there from the single duct or the multiple duct. And then what kind of discharge it is. You have to classify it to make us clear exactly from where the discharge is. Yes. The next thing or what I want to emphasize, you have said the past history of tuberculosis is present there. It is important to emphasize what kind of tuberculosis the patient had. Either have a pulmonary tuberculosis, have a tubercular lymphadenopathy, patient have a GI tuberculosis. You have to spell out what kind of tuberculosis has been the patient had there in the past and what kind of treatment the patient had received for that. You have not covered the history of allergy to the patient. It is very, very important to consider the history of allergy in each and every patient when we are presenting. Thank you.
Because tuberculosis, you can have even a sinus from the discharge from the chest wall also.
Yeah,
So
tuberculosis will be the possibility.
Yeah, that is why we are not riding on you, Chetan. We are just giving you all the possibilities to think when you see a case. Because one of the rare cases we get. Is it not for you?
Yes, sir.
So that's why you should mention where is the discharge coming from. Does it have a periodical discharge or non-periodical? And what is the flow? What is the type? All these things you have to say. That is what we are we're just teaching you, okay?
Yes, sir.
Don't get alarmed. You just note it down. So next case when you come, you should know. Okay.
You must now think in terms of carcinoma. Possibility of malignancy is the most common possibility. You get a breast means. So
Yes,
what are the possibilities? What are the predisposing factors for a male breast carcinoma to come or malignancy to come?
Sir, mainly because of the age factor, sir.
No, nothing will happen because age. Age is a very good thing. Age will not cause anything. Some changes must be there. Some predisposing factors must be there. What do you think? What are the predisposing factors for male breast carcinoma?
Sir, there can be any estrogen exposure, sir.
Very good. So anything just like a female breast, estrogen. So what are the condition you think in a male there's a possibility of estrogen excess will be there?
Sir, if a patient has any liver pathology like cirrhosis.
Very good. So there renal pathology and must be an alcoholic. So that all that history you are not elicited. Any problem in the testis?
Yeah, you should.
Yes, sir.
Syndrome.
Any
Yeah.
Klinefelter syndrome causes double X swelling.
At the age of 70, you are not going to think in terms of Klinefelter syndrome. But you must think in terms of the testicular injury, arthritis, even cryptorchid if it is there. If there is even a thyroid disease, when there is a thyroid, because all the TSH, FSH, all they will have the same pathology. So you need to have, or even sudden increase in the obesity, because the estradiol conversion possibilities are there. So in the history, you must always elicit what are the predisposing factors which this patient would have in cause. Whether he had a gynecomastia earlier.
No, sir. No history of any enlargement. No gynecomastia.
Is it gynecomastia is pre-malignant?
It can be, sir, but it is.
Per se, gynecomastia is not pre-malignant. But the condition which causes pre-malignancy, gynecomastia, if there is a testicular tumor, which is the result gynecomastia, so that estrogen excess can induce malignancy, or this lesion per se as a gynecomastia will not be the cause. It will not go turn malignancy on that. It is the causative mechanism for that can go in that. Is
any
married?
other carcinomas producing paraneoplastic syndromes, drugs, chemotherapeutic drugs, patient had other carcinomas, paraneoplastic syndrome, drugs, all these things you have to think over, which can produce breast enlargement. Okay.
You can, based only on the history, you have kept your diagnosis of carcinoma of breast. You like to keep any differential diagnosis based only on the history?
Sir, based on the history, he could also develop cold abscess, sir, as pulmonary tuberculosis history has.
Yes.
So there is a possibility of cold abscess.
So there can be the tuberculosis from the chest wall may be there. Cold abscess will be coming there. What are the other swellings which can occur if you get this type of the swelling which is there?
There can be tuberculosis of breast.
Yes, that is one is the tuberculosis you are told. Any other tumors you know that which can present like that in the chest wall?
So tumors arising from the chest wall, like any involving muscle bones, sir.
Yeah, any sarcoma can come. Sarcoma can be there from any tissue which is there. So that has to thought on the clinical history. No? Right. Okay.
We just had a case of myositis ossificans. So that was almost presenting like malignancy in the breast. So there are various reasons which we can think in terms of that. But don't put Paget's and inflammatory carcinoma. These two are very, very rare in the male breast. You don't think that.
Sir, Ajay Khanna, sir, is there a increase in the incidence of male carcinoma when the family history of female carcinoma is there?
Yes, it is there. Yeah.
Is there, sir?
It is there. Yeah, it is there. Yeah.
It is there, sir.
Yes, same.
Somebody having the prostatic carcinoma, somebody having the ovarian carcinoma, somebody having the colonic carcinoma.
BRCA 1 and 2.
Yeah. There is a possibility there. Yeah.
Yes.
And BRCA 2 is much more common there.
Yes, sir. Yes, sir.
Yeah, BRCA gene which is there is different in the male breast cancer as compared to the female breast cancer. But there is the BRCA gene which is there in the male breast cancer also. So there is a possibility of malignancy. Yeah.
Certain BRCA 1 or BRCA 2, which one will be more in the male breast cancer?
Sir, BRCA 2, sir.
And even 3 and 4 also, you know, there is a BRCA 3 and 4 also. So that can also be there. Yeah.
Should we move to examination?
Do this patient have a normal issues? How many issues patient have?
Sorry, sir.
How many issues the patient have? If the patient is married, then patient have a kids.
Yes, sir. He is a married person, sir.
How many kids the patient have?
He has 4 kids, sir.
He has 4 kids.
4 kids.
Yeah.
Any significance on that? The statistics shows the married man will have less malignancy. Like what we talk in the female breast cancer. So here also the man also it is important. Married man will have less incidence of breast cancer than the unmarried man. And also his testicular function. When he has 4 children, that rules out most of the problem which would have been there with the seminoma or all this in the second decade, third decade. So all that is also very important because the family history, you are just saying there is no similar complaints. As far as possible, don't use the word similar complaint. But if you can say specifically, you are talking about breast pathology or associated pathology, which is related to that.
See, when we talk about the Klinefelter syndromes, these patients, they have a normal male, you can say, pattern as such. And the only thing what they have is the infertility. So if the patient is infertile, then you may think of the patient may have this syndrome. Many times it is missed there unless until you have a karyotyping in these patients. Therefore, all those patients, they are, of course, they are the young patient in comparison to these patients, but you may always take a history of any infertility if it is present there with the patient. Thank you.
Why Klinefelter has infertility, Chetan?
Sir, because of the extra X chromosome, sir.
Then that is more, no? Extra chrome means you can be more healthy, more gentle. Like
because of,
another component is testicular atrophy. Testicular
atrophy, yes, sir.
You will not have the normal function of the
estrogen, the testosterone product. Shall I go ahead, sir?
Go ahead with the clinical examination.
Coming to general physical examination, an old age male who is moderately built and moderately nourished is conscious, cooperative, and oriented time-place person. And on examination, patient is afebrile and his vitals are normal and with no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or any generalized edema. Coming to local examination, inspection, patient was examined in standing position with arms by the side of his body.
Again and again in the class, we are insisting don't use the word local examination. What you are going to examine now?
Basically breast, sir.
Chest wall or the breast, whatever the reason, what you are going to use that word, what you are going to examine. Local examination do not give any meaning for that.
Okay, so left nipple is destroyed and is pulled up 3 centimeters up compared to the opposite nipple. There is a solitary ulcerated swelling of size 12 into 7 centimeters over the left anterior chest wall with grooves present. Each grooves extending 4 centimeters from the left lateral sternum. The swelling is extending 4 centimeters from the left lateral sternum border till the left anterior axillary line. It is irregular in shape. Indistinct margins are indistinct. Surface appears smooth except in the grooves. So this is the picture photograph of the patient.
Where is the 12 into 7 centimeter?
Sir, it is present in the lateral aspect of the chest wall, sir. Around 4 to 4 centimeters from the lateral border of sternum border, sir.
Ketan, you stumped us all after this picture. I mean, it doesn't look like a lump at all. It looks more like a retracted nipple, and it's a typical picture of malignancy, isn't it?
Yes, sir.
I mean, you're telling us that large 2 centimeters into 10 centimeters and discharge of watery discharge. I mean, we're all thinking of various things other than this. Okay, yeah, please.
So there is an ulcer of 2 into 1 present over the swelling in the medial aspect of the swelling, which is irregular in shape, sloping edges, granulating floor with minimal slough, with minimal serous discharge, with no signs of any inflammation, sir. Skin grooves are present in the lateral aspect, extending from the lateral aspect of the ulcer till the anterior axillary line, sir. There is no dilated veins. There is no visible swellings in the axilla. No fullness noted in the supraclavicular region. And opposite breast and chest wall appears to be normal. And patient examined with arms raised above the head. There is PUD orange is present in the lateral part of the swelling, sir, which is in the near the anterior axillary line. And arms over the hip, swelling doesn't become prominent upon contraction and relaxation of the pectoralis muscles. Coming to palpation, opposite chest wall, breast, and axilla are normal. All inspectory findings are confirmed. There is no local rise of temperature of the swelling. The swelling is non-tender. Left nipple is destroyed and pulled up 3 centimeter up compared to the opposite nipple. It's a solitary ulcerated swelling of 15 into 8 centimeter over the left anterior chest wall, extending around 4 centimeter from the lateral aspect of sternum till the left anterior chest and anterior axillary line, which is irregular in shape, with distinct margins felt all around except in the superior margin. This is the photograph, sir.
Go ahead.
The surface is smooth except in the grooves. Consistency is firm to hard. There is an ulcer of 2 into 1 centimeter over the middle aspect of the cell over the swelling, with induration all around except in the superior part. Skin is overlaying the superior border of the ulcer. Skin grooves present over swelling from the lateral aspect of ulcer till the anterior axillary line. Swelling is fixed to the pectoralis muscle. Skin is not pinchable over the swelling. There are small nodules noted of around 0.5 to 0.5 centimeter, 1 centimeter away from the medial aspect border of the swelling. And there is no any palpable axillary or supraclavicular lymph nodes. And in systemic examination, there is nothing eventful, sir. And there is no spine tenderness or deformity, and there, in the respiratory system also there is bilateral air entry equal with no added sounds.
Chetan, you said that the swelling did not become prominent over pectoral muscle contraction. What is that?
Sir, yes, sir. Meaning there is no. It's not an intramuscular swelling.
So if it is intramuscular swelling is there, or the swelling which is lying above the muscles, that will become prominent?
Cannot become prominent.
Sorry, sir. Any swelling on contraction, putting contraction, if the swelling becomes prominent, it's
contraction of the pectoral muscle is not a part of the inspection. It's a part of the palpation, isn't it? Where you want to see whether this particular swelling which is there in the breast is fixed to the pectoral muscle or not. So you do not see for any prominence, but you see only for the fixity. And as such, you are not told whether this swelling is mobile or not.
Sir, sorry, sir.
You
The
did not
swelling
mention
is
about that.
Sir, the swelling is non-mobile, sir.
If the swelling is not mobile,
with there is no non-mobile in along the direction of pectoralis fibers or opposite and perpendicular to the fibers, sir, when muscle is put to contraction.
Chetan, I'll just like to tell you that in chest wall, contraction of muscle and all is not there. We cannot interpret the level of the swelling other than whether it's on the skin or below the skin, right? It's not important here. Like in the female breast, we see fixity to the muscle and to the chest wall. You have to do the same thing here or to the skin. And you got to interpret it the same way.
Yes, sir. Of mobility, fixity.
So is it fixed to the chest wall or not?
It is fixed, sir.
It's fixed to the chest wall. How did you know that's fixed to the chest wall?
Sir, by putting the muscle in contraction, then moving the whole of the swelling along the direction of fiber and perpendicular itself.
Which muscle? Which muscle?
Sir, pectoralis major muscle.
That is not chest wall.
Look, if the swelling
Also,
cannot move at all, it's fixed to the chest wall. There's no mobility as such, isn't it? So here the contraction of the pectoralis muscle does not arise. Is it fixed to the skin?
Yes, sir.
Obviously.
Skin is not pinched.
Obviously, you can see that it's fixed to the skin. And there you said there's pody orange also.
Yes, sir.
Right. What were the lymph nodes, axillary lymph nodes?
Sir, there is no palpable axillary lymph nodes.
No supraclavicular, nothing?
No, sir. No supraclavicular and no axillary lymph nodes palpable.
Do you think it's this is the would you expect lymph nodes, or wouldn't expect lymph nodes with this kind of condition? Where there's an ulcer and could someone mute Lakshmi?
With such a presentation, lymph nodes are expected, sir.
Okay. So, okay, come to your diagnosis. What's the diagnosis now?
What is that skin groove? You are repeatedly saying there is skin groove, skin groove. What is that? What do you mean by skin groove? It's a new word in malignancy.
What
would you call that?
It's a word like a groove. What is that?
Why is that groove formed?
Skin retraction.
Yes. Skin retraction.
Basically, skin retraction, sir.
So, what's the diagnosis now? Has there been any surgery before on this?
No, sir. There is no any previous surgery history, sir.
Nothing been done on him.
No, sir.
It looks a little different, no, sir?
Yeah. It looks as if some surgery has been done. Okay. So, what's the diagnosis now?
Sir, I would like to give a project diagnosis of CA carcinoma of breast, sir. CA carcinoma of left breast with a clinical staging of T4B N0M0, sir. It's stage B, which is a
Chetan, of course, before we proceed, just I want to emphasize exactly you are meshed up with, you don't know exactly what is the difference between a fixity there to the chest wall and the fixity there to the pectoralis muscle. You must be able to differentiate it clinically as such. If something is already fixed to the chest wall, you are not supposed to check for the fixity there to the pectoralis muscle. Is it okay? And now you are making a diagnosis of carcinoma left breast as such as a first diagnosis. So you want to keep other differential diagnosis along with it because there is no lymphadenopathy. Already patient has stage 3B disease. So what do you say?
Sir, with the discharging ulcer, we could also think of cold abscess, sir.
It is not a cold abscess because it is not a cystic swelling which is there. So we can talk about, if you want to keep, you can keep a diagnosis of a tuberculosis breast as such, which can masquerading like a carcinoma breast as such here.
Sir, as there is involvement of nipple and alveolar complex, sir.
Yeah, it may be seen. It may be seen there in the patient with the pulmonary breast tuberculosis also.
You have repeatedly said nipple is destroyed, and again saying nipple is elevated. What is right? Your first sentence said nipple is elevated for 3 centimeters. Next, you have said nipple is destroyed.
It's a destroyed. Nipple is destroyed.
Then what do you want to say? Nipple is elevated. So be specific. What is that? Definitely that is the areolar flux. Entire thing is gone up. Ulcer is there on the right at the examination. Also, you are not examined scrotum. You are set up the spine, but that in the Senais are repeatedly used to say 3 years spine, skull, and the scrotum. So always do not, especially in this case like this, when you are seeing other causes for the gynecomastia, it has to be looked for.
Yes.
So, what do you say it is with T4B? You said there is a.
Sir, it will be T4C, sir.
Yeah, just skin fixation is there, chest wall fixation is there.
Both are involved.
But you have
T4C, sir. Sorry, sir. Not T4.
What constitute the chest wall? What do you mean by chest wall?
Sir, chest wall includes of rib cage, interpectoral muscles. Interpectoral muscles.
What is that?
Sorry, not intercostal muscles. Sorry, sir. Intercostal muscles.
How many intercostal muscles are there?
3, sir.
3. Okay, good. Then any other muscle?
Sir, serratus anterior in the lateral.
Serratus anterior also comes as the part of chest wall fixation. So it is very, male breast is known because there is a bulk is not there. Very commonly they will present with the chest wall infiltration. So that is why the percentage of stage 3 or the T3, T4 lesion is very high in the male. Very easily they go for the fixation into that. So how you are going to proceed?
What are T4B lesions? What are T4B lesions?
Sir, T4B mainly involves all the skin involvement, sir, like PUD, orange, dimpling, skin retraction.
They are all the part of the T4B.
Dimpling also.
No, nodules, sir, skin nodules.
There are only 3 things which are there in the T4B lesion.
PUD orange, skin nodules, sir.
Satellite nodules and the ulceration. Okay, so these are only 3 things which are there. Nipple retraction, dimpling, retraction, all those are not T4B lesions. No, they are the skin changes which are there which can occur in the cancer breast, but they are not the T4B lesions. Okay.
How you are going to proceed?
Sir, I would like to get. I would like to work up and confirm the diagnosis, sir. So I would like to go ahead with coroneal biopsy, sir. Then for coroneal biopsy with the hormonal receptor study, sir. And also I would like to get an metastatic workup such as X-ray of chest, spine, ultrasonography of abdomen, and CT thorax.
So the triple assessment do not play a role here, no? So you think the triple assessment is not necessary for a male carcinoma?
Yes, sir. As breast tissue in male, breast tissue is less. There is no breast tissue, sir. So
no breast tissue. So how can then get the breast carcinoma? If there is no breast tissue, there
Chetan, you got to treat this just like a female breast cancer. Do everything. We're telling you this right from the beginning. It's the same thing.
So yes, the original diagnosis, mammography, and things, it has to be. You have to say bilaterally. You have to do calcification because still you can have a gynecomastia that can be differentiated when you have a difficulty. So better to go and follow the same protocol.
Yes, sir.
So here there is an already ulceration. So you want to do a coroneal biopsy here?
Or we can go with wedge biopsy, sir.
No, it is only you have to present what you are going to do for your case. The case is already present to you with a 2 into 1 centimeter ulcer.
Can go, wedge biopsy would with involving the base of the ulcer and involving the margin of the ulcer.
Chetan, before you proceed, you must know whether the male breast cancer, they should be evaluated in the same pattern as the female breast cancer or not. So do you feel like, and with your presentation, I can very well understand that you don't have a concept that male patients, they should be evaluated similar to that of the female patients. So I think you all know the investigation we do there for the breast cancer in the females. So what should be the sequence of the investigation which is to be done. It's not like the core biopsy, you directly go for the core biopsy in the patient before doing the imaging, whether the imaging is to be done or it is a biopsy is to be done first, which is to be done first, and reason behind it.
Sir, initially we are supposed to do non-invasive radiological studies, sir.
See, the imaging is to be done first, then you should go ahead with the biopsy. That is the, I think, dictum with all cancers, all sarcomas when you are treating with. So what imaging you will do here in this patient? In this patient I'm talking about.
Go ahead with mammography, sir.
Yeah, you can do a mammography in the male patient also. Is it clear? So yeah, if you're not comfortable with the mammography or you won't have a facility, what other imaging you can do it here?
We can go ahead with MRI of the chest, sir.
No, why you want to have MRI? You have an ultrasound with you, which you can do it. Why you want to have MRI? There's certain indication of prescribing MRI to a female patient that doesn't fit it here. Even those indications are not being indicated there in the male patients. You can do ultrasound here. You have written here the ultrasound, but ultrasound of the abdomen, it is ultrasound of the chest wall is to be done here in this patient. And then you can go for a core biopsy. It's okay. And if the patient have an ulcerated lesion, you can also do a, what kind of biopsy? You can do it in an ulcerated lesion.
Edge biopsy.
It's okay. I think other can take over.
What you are going to expect in the biopsy?
Sorry, sir.
No, you have taken the edge biopsy and sent for histology. What you are going to expect in the report?
Sir, they expect any ductal pathology, sir.
So you are thinking in terms of malignant carcinoma. So what kind of carcinoma you are going to think, and what will be the histological feature?
Sir, most commonly think of invasive ductal carcinomas.
Okay. So what will be the picture of the histology?
Can be having
see, the characteristic feature of each histology you must know. So what is now if it is adenocarcinoma? So what you are going to expect in the breast? What is the scoring? You know, Bloom-Richardson scoring. What are the things you look in that scoring? So you're not read that the tubular formation, mitosis, necrosis. So that's what you are going to do. So now in a female breast we get a lobular carcinoma. What percentage of a male breast will have lobular carcinoma?
Sir, it is very less, sir. Less than 20%, sir.
20%, even in female, it is only less than 20% you have. So it is very, very less. That's 1 to 2% or 3% the maximum. Lobular carcinoma is not much reported. So most of the carcinoma which is reported in a male is infiltrative ductal carcinoma. So that is if at all talk about some difference in the male and female breast, then this is one area where you get. Second, you are going to do the tumor mark, ERPR also. Yes, so is there any change in the ERPR status in the male and female breast carcinoma?
Yes, sir. Compared to female, male has more has ER and PR positivity, sir.
Again, it is nearly 90-95% will be ERPR will be positive. Most majority of the tumors of the breast of the male is ER positive, infiltrated ductal carcinoma. They will not be at a lobular carcinoma, will be very less, and triple negative cancer is also very less in the male breast. It is less than 4% only. You have a triple breast. So when you are taking histology, it is not just a routine you are going to take. So you must know what you are going to send and what the report you are going to anticipate from the report. Then only otherwise you will not be able to interpret it in proper way. So grading also not much important in the male breast carcinoma. Like what we talk about the female breast carcinoma treatment for the grading. So here it is not going to be a major difference. It's ERPR, but there are a few other indicators, other factors which we count, but that is beyond your scope. But at least this histological, what you are going to expect, you must know. So you have got the result, and now you have to, as you have put rightly, then metastatic workup you are going to do. Puneet sir, you can follow.
Yeah, the few things, Chetan, again, I want to emphasize here, even the mammogram findings are totally different there in the male patients. You won't have many calcifications seen what you can get in the female mammogram. So mammogram findings are also a bit different there in the male patient if you evaluate these patients. Next, what you have written here regarding the metastatic workup, the patient have a locally advanced breast cancer, which turned out to be a carcinoma. So is it not the bone scan you are going to prescribe? Because as per the NCCN guidelines, all locally advanced breast cancer should have a bone scan done for the metastatic workup rather than being X-ray chest and spine, what you have written.
Yes, sir. Bone scan is needed.
Bone scan is recommended for all patients presenting with at least with a locally advanced breast cancers. It is a mandatory requirement. Of course, what you have said is the CT abdomen and the CT thorax. Of course, the CT thorax you can include. Why the CT abdomen you have included when you have already done the ultrasound of the abdomen?
What you are going to expect in the abdomen?
Sir, for any liver metastasis, any ascitic fluid or any deposits in the
again, it is very less because what type of carcinoma will produce transcelomic spread?
Metastatic.
You have a mucinous carcinoma, which is not much common. Because you have either intraductal carcinoma, again, that is a papillary variety will be common. So you don't have much reported. So you can routinely you can do, but not you don't get much influence on the abdomen. Infiltration or ascites is not a common feature to have in the male breast cancer. So in this, there is nothing to do both ultrasonography of the abdomen and then CT abdomen. What is the advantage over CT? I mean, ultrasound on CT? Anything fresh you can note from the CT?
Sir, any deposits or deposits, and also we can spine.
That ultrasound also will be given.
Spine.
Ultrasound will be given.
You can also get to know about the spine status. Sir.
Spine status. Which spine?
Sir, a lumbar spine, sir.
So lumbar spine is the commonest. So where do you expect the secondaries in the spine?
Sir, because of Batson plexus.
Where? Which part of the spine you will have the secondaries?
Sir, in the pedicle part of the spine, sir.
Okay. How it looks like in the.
Sir,
ouli appearance.
Oh.
Okay, it's a pedicle. It's near the body. You can get on the other side. You will get. So even for looking for the tenderness, you should not see in the midline. It is on the other side. On the side only, you will be getting that.
Will you do the liver function test in this patient?
Sir, yes, sir. A liver function test.
Okay, you have done the liver function test and the alkaline phosphatase comes out to be raised. What is the significance of that?
Sir, it implies there is a pathology involved of the liver, sir. So
only the liver?
Yeah.
In the carcinoma breast. In the patient, you are suspecting carcinoma breast, the alkaline phosphatase is raised. Will you think only of a liver?
Also for spine, sir.
Any bone, no?
Bone, yes, sir.
Any bone metastasis which is there. So how will you differentiate whether this is because of the bone metastasis or because of the liver metastasis?
Sir, by getting imaging modality, sir.
No, biochemical. Biochemical investigation.
Yeah. Like to get an.
You have done a liver function test already.
You will do the subtyping of the alkaline phosphatase. There are different types of alkaline. One is the heat labile, and another the heat stable is there. And it is different in the liver mats and in the case of the bone mats. Okay, and then if you find the bilirubin is raised, then it's likely to be liver mets if it is there. And if what will happen in the bone mets, what will be raised in the biochemical?
Osteolysis. So what will happen?
So more of
In
calcium.
the blood, what will happen?
Calcium will be increased.
Yeah, calcium. So if you find a raised calcium, then it is probably likely to be a bone metastasis. Okay. You know, what are the various clinico-pathological types of breast cancers? Not the male breast cancer, but as such, I'm just asking. What are the various types of clinico-pathological types of breast cancer?
So, invasive, in situ and invasive.
That is histological. I'm asking clinico-pathological.
That is anatomical. What you are saying is anatomical.
Clinico-pathological, like it may be medullary carcinoma, it can be a serous carcinoma, it can be a trophic serous carcinoma, it can be the Paget's disease, it can be inflammatory carcinoma. So they are the all types of the, what are called as the clinico-pathological types of the breast cancer.
Now it is NOS, not otherwise specified.
Okay, so what is your plan in this patient now?
Sir, as it's in locally advancing breast carcinoma, sir, I'd like to downstage it first, sir, by giving neoadjuvant chemotherapy, following which we could go with surgical intervention, and we can go with chemotherapy, adjuvant chemotherapy, and radiotherapy with hormonal status.
What is the surgery you are going to do?
Sir, we like to go ahead with modified radical mastectomy, sir.
No, you said it is fixed to the pectoralis major, it is fixed to the chest wall.
Along with then we have to consider removing pectoralis muscle also, sir. With radical mastectomy, sir.
What do you understand by radical mastectomy, Chetan? What is the meaning of radical mastectomy?
Sir, radical mastectomy is removal of breast tissue, nipple and areolar with with removal of pectoralis major.
And
Pectoralis minor also, sir.
so you remove the whole of the pectoralis major? Do you remove the whole of the pectoralis major? How many heads are there in the pectoralis major?
2 heads, sir.
So you are going to remove both the sternal and the clavicular heads?
Only the only the clavicle until clavicle head, sir.
Sternal you remove. You preserve the clavicular head, otherwise you will damage the cephalic vein there. Okay, if you damage the cephalic vein, then in that case there is a lot of chance of having a lymphedema. Okay, so you are only removing the sternal head, not the clavicular head of that.
Certain what I expected from you, you should have said, I have given a neoadjuvant therapy and I expecting the response to the treatment, so that the tumor size should have been reviewed. Then you can go for with the simple mastectomy. Don't change your plan just because we are asking questions. Suddenly go say I will do radical. Whatever you have an intention, you must have a wide scope, then go ahead with that. Normally nowadays it is not recommended to do the radical mastectomy. So now the patient is ERPR positive. So will you start on a chemotherapy or a hormonal therapy?
Along chemotherapy, we have to complete 4 cycles of chemotherapy, and we have to start with hormonal therapy also, sir.
What hormonal therapy you prefer for male?
Sir, tamoxifen, sir. For over 5 years.
It is a 70 years old male. The female 70 years old, what do you prefer?
No,
70 years old, if you are giving a hormonal therapy, what is the choice? So aromatase inhibitor. But here in a male, you don't give aromatase inhibitors. The only drug of choice is tamoxifen. If you want to give, if that is ERPR, tamoxifen is not responding, while you are giving aromatase, you must always start along with the GnRH annular. Both should be combined together and given. Not alone, aromatase inhibitor should not be given in a male. So that's another difference in the treatment protocol which we are following in a male and breast discussion.
Any surgical treatment for the hormonal treatment? Any surgical treatment for the hormone?
We can go with orchidectomy, sir.
What type of the orchidectomy you will do for the cancer breast?
A bilateral orchidectomy, sir. But
any type of that? Or you just remove the testes?
High-end orchidectomy.
It is not required high orchidectomy here, but some other type of the orchidectomy which is there. You know, one wants to lose the testes. So you have to give that sense to the patient that his testes are still there. This is called a subcapsular orchidectomy. Okay. Where you remove the active substance of that, but you maintain that capsule which is there, okay, whatever the thing with the tunica and everything which is there, but you are only removing the active part of the testes. So that the hematoma formation is there after you have done that. So the patient will feel that his testes are still there. Okay. So this is a subcapsular type of the orchidectomy.
Why do you want to do orchidectomy?
Sir, because as the in the increase in the age, there is a decreased testosterone production, sir. And there is the increase in estradiol in the male body, sir.
There is always a combination between estradiol and testosterone. Already testosterone is low. You want to do orchidectomy, it is going to further reduce the testosterone. So relatively, estrogen will increase.
Chetan, I think it is very clear to you now that Dr. Jailal has said that you must use a tamoxifen as a first-line chemotherapy, hormone therapy in these patients, rather than being a aromatase inhibitors or orchidectomy as such. Orchidectomy nowadays is not done as such because it has got certain social issues, and therefore it is not been preferred. It is better to use the other form of therapy which is widely been available here. Have you evaluated this patient? Do you have any report regarding these patients?
Sir, we had got this thing, sir. IRPR status, sir.
No. First is the histology. You must tell about the histology. What is the histology? And second is, do the patient have any metastatic disease or not? So
sir,
what is histology?
Histology basis, it came out to be invasive ductal carcinoma, sir. And here hormonal status, it came out to be ERPR and HER2 positive, sir.
So you see, as Dr. Jailal has said, that most of these patients, they are ERPR positive. See, if you combine that, more than 90% of them, they're 92 to 95% of these patients, they are ERPR positive. So they respond to very well to tamoxifen. So it may be used there, although there is a controversy whether you can use as a neoadjuvant therapy or not. But of course, as an adjuvant therapy, it must be used. The hormone therapy must be used as an adjuvant therapy. But when you are using it like a neoadjuvant chemotherapy, neoadjuvant setting, it is mostly the chemotherapy which has been preferred. And then in the post-operative period, after completing the chemotherapy, you can use the hormone therapy in these patients. And both the therapies should not be combined at the same time. It must be remembered. So, okay.
Yes, sir.
And
Yes, sir.
of course, we all know about the indication of radiotherapy in these patients. As it is true there for the female patient, it is also true there for the male patients. And the indications are very limited, that if the size of the tumor is more than 5 centimeters, if the margin of resection is positive, or the patient have a massive lymphadenopathy, if it is more than 4, some says, or some says it is 1 to 3 with the extranodal disease, then you can use a radiotherapy. So this is the way exactly how this patient is to be treated, in the same way as we treat there for the female patient. But it is important to remember exactly the endocrine therapy or the hormone therapy is preferred in these patients, and they should be used widely, because most of them, they are ERPR positive and they respond to very well, unless until they have a certain visceral crisis, what we call it as, we should not switch over to the chemotherapy. The hormone therapy mostly be used there for the patient. Thank you. Anyone can
Even
take.
for metastatic breast carcinoma, the first line of management is only endocrine therapy.
Endocrine.
As Sarah said very well, only when a visceral crisis, you go for the chemotherapy. Otherwise, it is only endocrine. Will you think of a BCS in this case? Definitely not in this case. Or a male breast carcinoma, will you think of a BCS?
No, sir. BCS.
We can't say absolutely no. Now there are a lot of people started doing for BCS also, but normally, as far as our standard and our thing, we'll say we'll not think of BCS for because the relative size of the breast to conserve will be very less. We will not be able to do that. But that is also an option. When the person is asking you, you cannot say absolutely no. You have to say the reason and why you are saying no. Why in male breast is not going for a carcinoma much? You have a very limited incidence.
Sir, mainly because of hormonal exposure, sir. There is no estrogen exposure and there is no lobular content of the breast, sir.
Terminal ductal lobule, that is the unit from which that cancer. So normally that is not there. That is why we don't get a lobular carcinoma. Even as we are getting, it is only infiltrated ductal carcinoma. Lobular carcinoma will not be there. So how will you follow up the case? What is the chances of recurrence?
Sir, chances is around 15 to 20%, sir.
So comparing the female breast, the recurrence is more in the male breast, especially when the carcinoma is in a male patient who is less than 50 years. The possibility of recurrence is more, and within up to 15 years, it can go for. So you need to follow up the patient for more than 15 years daily to see whether there is a look for. So will you suppose there is a role of sentinel node biopsy in a male breast carcinoma? Again, it's a controversy. As of now, your patient has no node positive. There's no node even after the chest wall fixation. The node is. So at this stage, will you do sentinel node biopsy, or will you go for axial dissection?
Sir, it's better to go with axillary dissection, sir. We can do central node biopsy, sir, but considering his age and with the clinical staging, sir, locally advanced, so it's better to go ahead with axillary dissection.
You already said there is ulcer having a fibrosis will be there. So this doing a sentinel node biopsy will not be of ideal one. So there is. You said there is few nodules also seen. No? You have seen some nodules on the chest wall.
Yes, sir.
How will you explain the nodules?
Sir, it is cutaneous manifestation, sir. Due to involvement of lymphatics, lymphatic
what is the
involvement.
specialty of the cutaneous lymphatics of this breast?
Cutis and
cutaneous lymphatics is mainly a segmental. So that is why they will have very, very less communication with the neighboring segment. So once we go to the particular segment is blocked, so there all these tumor cells aggregate and they produce multiple nodules on that. So you have seen that the two nodules are there.
Yes, sir.
It was seen more towards the medial side.
Yes, sir, to the medial side, sir.
So have you looked for your interpectoral nodes, or you have seen the intercostal nodes?
Yes, sir. It was observed, sir, but there was no lymph nodes over palpable. I have seen, sir.
How do you clinically note for that?
Sir,
How do you clinically for the intercostal?
so we have to palpate deep palpation of the axilla and along with the supraclavicular.
Intercostal is
Sorry.
internal thoracic nodes.
In the medial aspect of the chest, sir. Palpate along
How will
the.
you examine?
Sir.
Palpate. You can't palpate intercostal in internal thoracic nodes. What you will say in the female breast? Suppose you.
To go.
So percussion on the third, fourth, fifth intercostal space on the parasternal border. Okay. Good. I think Kanavel sir will be able to close. Saravanan sir, you have joined. Saravanan sir, you have.
Sir,
Join late, sir. Sorry,
we
sir.
can, sir,
Yes, sir.
if other faculty agree, then I think we can move to the next case, sir. He's going to be from Dr. Vamsi Krishna from Guntur Medical College, sir. I think we should allow Chetan to ask any questions does he have. Chetan, do you have any doubts or questions now?
Yes, sir. Sir, as this patient was known tuberculosis case, sir. Sir, as isoniazid has a side effect of gynecomastia, can it be a cause, like predisposing factor for in this particular case, sir?
Absolutely no. Per se, gynecomastia, which is caused, will not produce malignancy unless it is due to the estrogen excess etiology, either due to the cirrhosis, either due to the testicular malignancy or Klinefelter syndrome. That gynecomastia, that because of the background estrogen excess, can turn into the malignancy.
Thank you, sir.
Drug use will not cause.
Thank you, sir. That was my doubt, sir.
Thank you, Dr. Chetan. Thanks to our due to your professors. Can I now request Dr. Vamsi to share his PowerPoint and start his presentation?
Thank you so much, sir.
Dr. Vamsi?
Yes, sir.
Yes, Vamsi, please switch on your video. Please introduce yourself, your unit chief, your head of the department, and start your presentation. Good luck to you. Faculty, please take over.
Yes, sir. Good evening to everyone. I'm K. Vamsi Krishna from Guntur Medical College. I'm going to present a case of swelling over neck under guidance of my professor, Dr. P.A. Ramani, and she is a professor of general surgery from Guntur Medical College. A 64 years old male patient by name of so-and-so. He is an agricultural laborer by occupation, and he is a resident of Guntur. Came to the VGH Guntur with chief complaints of swelling over neck since 4 months on right side. Coming to the history of present illness, he noticed the swelling of 3 into 2 centimeters present over the right side upper half of the neck, which was insidious in onset and gradually progressive and attained the present size of 7 into 5 centimeters. And there is no history of pain and no history of fever and no history of difficulty in swallowing and no history of difficulty in mouth opening and no history of change of voice and no history of drooling of saliva. And there is no history of halitosis and no history of ear discharge, earache, and no history of nasal block and bleeding from the nose. And there is no history of loss of weight and loss of appetite. And there is no history of cough, breathlessness, and hemoptysis. Coming to the past history, there is history of similar swelling present 10 months ago with over the right submandibular region for which he approached a local practitioner and he did some procedure. And that wound was not healed, and he came to the GGS for treatment. After giving antibiotics, it was subsided. And he is a known hypertensive and diabetic since 15 years. He is on regular medication. And there is no history of bronchial asthma, pulmonary tuberculosis, and epilepsy, and no history of radiation exposure. Coming to the personal history, he has a habit of chewing palm since 25 years, and daily. And there is no history of alcohol intake and no history of smoking. He takes mixed diet, and bowel and bladder habits are regular. Family history is little significant. Coming to summarizing my history, a 64-year fan chewer with right-sided painless neck swelling over the upper half of the neck with similar history of swelling over past 10 months ago.
Vamsi, am I audible?
Yes.
Vamsi, you have said difficulty in mouth opening. Any what for difficulty in mouth opening? Yes.
Any malignancy?
Hello.
Hello.
Hello, can the non-participants mute themselves, please? I think it's Dr. Kanav. Okay, I think.
விட்டுட்டு வர முடியல.
Yes, sir.
I'm sorry, sir. I'm sorry. ஒரே நிமிஷம்.
Yeah, go on, please.
Yes.
Okay, Vamsi, what do you think is your diagnosis now?
Yes, sir.
By your history, palm chewer, painless swelling on the right side of upper half of the neck.
Yes, sir.
With similar swelling in past 10 months.
Sir.
Can you hear me?
Yes, sir. Audible, sir.
Yeah, so what do you think is your diagnosis?
Any lymph nodal swelling ranging from the cervical lymph nodal region. Most probably the swelling is in 4 months history, so most probably malignant swelling at the age of the patient, and there is a history of pan chewing. They're all favor of.
So you couldn't find a primary by history.
Yes, sir.
So
by
what will you call that then?
Unknown primary. Unknown primary. Clinically unknown primary, sir.
Clinically undetected. It's called CUP.
Yes, sir.
Carcinoma of unknown primary. Okay. So, okay.
Have you asked all the history of various primaries you are thinking of? It could be a primary from nasopharynx. So what could be the history patient may have?
If it is arisen from nasopharynx, there is a nasal blockade and ear discharge, earache, and hardness of hearing is there, sir.
Have you asked that history? It is not mentioned in your history.
So there is
nothing
no
was not said about the pain in the ear or the loss of hearing, you are not mentioned.
Yeah, Vamsi, now you have to, your history has to expand tremendously to include the upper aerodigestive system.
Yes, sir.
Which is not there. Okay.
Okay.
See, stars are asking, you have to ask for the history of lymphomas also, history of night sweats, any itching.
Okay. There is no evening temperature, night sweats, and
yeah, that also to be included. What about the mouth opening? You ask for difficulty in mouth opening. Why neck swelling going for mouth opening? Difficulty? Is there any reason?
if any malignancy arising from oral cavity, it will restrict the mouth opening.
Okay, here no such history of any oral lesions. Okay, dribbling of saliva also you asked for. Why you ask for dribbling of saliva?
Any malignancy arising from posterior 1/3 of the tongue, the saliva is and he is unable to swallow. If the saliva, then it will dribble from the mouth.
Okay. You said some submandibular lesions. Can you connect with the present swelling in the neck? What could be the submandibular lesions?
Maybe that was a lymph node which was excised by a local practitioner, maybe possibly lymph node.
Lymph node can be isolatedly excised in submandibular region. What is the location of submandibular node? Is it very close to the submandibular gland or not?
Yes, sir.
Then what is the type of surgery? Either removing the node alone or removing along with gland also.
Along with gland, sir, we will remove.
Most probably, you cannot remove the submandibular node separately. Okay. Usually, it will be embedded in the gland. Okay.
You have that biopsy report? Do you have the biopsy report of that?
Yes, sir.
No,
but the biopsy report is not available.
Hello. Hi, Kamal.
How are you?
You have said 25 years of chewing palm. What is the significance of that? Varmaji, are you here? There is a 25 years of chewing, palm chewing. Why you are particularly asking that history?
There is some premalignant lesions of oral cavity or say will be seen in pan chewing, like oral submucal fibrosis or leukoplakia or erythroplakia.
So that is the reason.
Yes.
So you are having a node there, and what malignancy it will produce?
Squamous cell carcinoma.
Squamous cell carcinoma only. What is Indian oral cancer?
Hard palate.
Hot palate. Indians are not famous for the reverse smoking much.
Yes.
But we are getting much of this. Gingival buccal sulcus. What is good? Okay. So don't just pass a statement like that and you must, whatever the reason you are asking.
Vamsi, I just want to tell you that this is a case of probably unknown primary, right?
Okay.
So you will have to work your history, ruling out each of the lesions which can give you a neck swelling. Secondaries in the neck or primaries in the lymph node, right? You'll have to work your history that way.
Okay.
See, not only concentrating on the upper aerodigestive tract, oral cavity, head and neck. What are the things below the clavicle that may cause secondary deposits in the neck nodes.
Yes,
But
sir.
also history you have to include. At the history
Yes, sir.
level, you should not go to the conclusion that is from the oral cavity and area history alone. What are other regions from there? Make it deposit
From
in the lung.
from
Yes.
lung bronchoscopy carcinoma, sir.
Yes.
And
Then
from breast.
then
From
kidney, testis,
yes, sir. Testis.
even abdominal organs, esophagus. Okay, that history also to some extent you have to collect.
Yes.
You are at the primary level. Okay, history take. Okay. Yes. You ask for history of radiation exposure. Why you ask for radiation exposure connecting to the neck swelling?
History of lymphomas, sir. Any exposure
Treatment
to
or etiology?
etiology, sir.
Etiology.
Etiology, then you have to ask the history of lymphoma, not the radiation.
Vamsi, I want to emphasize, I think most of the things has been covered. A few things I want to add it on when you are talking. Hello, I'm audible as well.
Yes, sir, please go.
Yeah. When you're taking a history, a personal history, you must ask the history of punching. It is not the punching which is important. It is important to know that whether patient takes erica nut along with that, patient takes tobacco along with that, patient takes pan masa along with that, patient taking quid there. So Dr. Jayalal has asked, what is quid? Do you know what is quid?
No.
Quid in Hindi we call it as khani. It is a tobacco mixed with slack lime, and the patient used to put there inside the mouth in the two areas, that is gingivobuccal sulcus or gingivolabial sulcus. And those patients where the patient put a quid, they have a higher chances of developing a malignancy of the GB sulcus or with the gingivolabial sulcus, depending upon where they used to put a quid. So to ask this history in detail in all patients with a, if you are suspecting a case of a oral malignancy. Along with that, when you're talking about the malignancy there in the upper digestive tract, it is important to include the smoking, history of smoking, history of alcoholism, which is present there to the patient. So all these things you must ask to these patients, because it is not only the upper digestive tract you are talking about, even the bronchogenic carcinoma we can talk about, they can predispose, they can present with secondaries there in the neck. So it is important apart from the things what has already been discussed. Thank you.
You have a multiple. Once you had a submandibular region, now you have a region. Why don't you think of tuberculosis etiology?
There is no history of fever, and there is no history of cough, sir. There is no history of evening.
Lymph node tuberculosis, extrapulmonary or intrapulmonary?
Extrapulmonary.
So why should you are expecting cough in extrapulmonary tuberculosis?
No.
So when there is a malignant lesion, when there is a lesion, you are saying lesion was there, it has been removed or subsided. So we don't expect a lesion like that.
Yes.
So you have to have in the mind of other lesions of the tuberculosis also has to be in the mind. What is that relative rule of 80? If the lesion, non-thyroidal lesion, neck node will be of tumor, 80% of will be malignant, 80% of will be secondary, 80% of will be from the male, 80% from the supraclavicular area. So the most common tumor is you are going to get from the supraclavicular region. It's a squamous cell carcinoma. 80% is squamous cell carcinoma.
Yes.
In the male, is common. You are going to get from the above there. The rest you have to think, as both Saravanan sir and Puneet sir has explained, all other cancer also you have to think. Then only your history will complete. Especially in a unknown primary, your history should be widely covering all this area, all the possibilities you have to come, and then you have to proceed with that.
Okay.
Now you can go ahead with that your clinical examination.
Sir, coming to the general examination, patient is conscious and coherent, moderately built and nourished, orientation to time-plus person present, anemia is present, no icterus, no cyanosis, no clubbing, no pedal edema, and no generalized lymphadenopathy except for cervical lymphadenopathy. The vitals are patient is febrile, pulse rate is 78 beats per minute, regular in rhythm, in normal volume. Blood pressure is 130/70 measured in left arm in supine position. Respiratory rate is 19 breaths per minute. And this is the image, clinical image.
So one comment, you can say there is no generalized lymphadenopathy, that's all. What is the definition for generalized lymphadenopathy?
More than 2 lymph nodal groups are involved.
Yeah, here it's only solitary swelling, single swelling, yes. Then you need not commit. There is no except. There is no generalized lymphadenopathy except like that you need not commit. Okay.
Okay.
That comes under your local examination.
Okay.
There is no generalized lymphadenopathy. That's all. Okay.
Okay.
Yes.
Coming to the examination of neck, after taking proper consent, patient was examined. On inspection, there is a single vertically whole swelling of size 7 cross 4 centimeters present over right side of the middle one third of the neck. Superior and inferior borders are defined and irregular. Superior border is 3 centimeters below the angle of mandible, and the inferior border is 5 centimeters above the medial one third of the clavicle. Anterior border is 3 centimeters away from the midline, and posterior border is not clearly defined. And the skin over swelling is normal, and the surface is irregular, and there is a 5 centimeter horizontal scar present over the right submandibular region, which is depressed. And no other visible swellings on the same side and the opposite side, and the trachea appears to be in midline. Coming to the palpation, there is
Okay.
no.
Wait, just a minute.
Okay.
Inspection, you have to say from which position you are examining. You are examining in the lateral position, or from anterior, or from posterior. Like that, you have to say. Okay. In the sitting position. These things you have to completely say. In the sitting position, arms by the side of the patient, with slightly extended neck or something like flexor neck. Which one? Or turning the neck to the opposite side or not? Like that, you have to say. So here the swelling is in the right side. Slight extension, turning the neck to the opposite side. I have examined, inspected, done. Okay. Also, your anterior extent, you are told from the midline. You need not stay from the midline. Is the sternomastoid visible or not? Sternocleidomastoid.
No, sir. After turning it to opposite side, it is common.
Is it visible or not?
Yes, sir.
You can say according to the posterior border of the sternomastoid, you can take into account, so that it fits which triangle, major triangle, the swelling is, whether it's the anterior triangle of the neck or posterior triangle of the neck. Because diagnosis, we can diagnose to some extent by inspection itself, which triangle the swelling is actually placed, right?
Okay.
So need not take the anterior extent at the midline of the neck, posterior border of the sternocleidomastoid. That can be taken into account. Okay, proceed to palpation. Yes.
Coming to the palpation, there is no local rise of temperature and no tenderness. Swelling of 7 to 5 centimeters present over the right side of the neck at the level 3 cervical lymph nodal group, and it is extending 3 centimeters below the angle of mandible and 5 centimeters above the medial one third of the clavicle. And lateral border is extending 2 centimeters beyond the right sternocleidomastoid, and medial border is anterior to the posterior border of sternocleidomastoid, and skin over the swelling is principal. It is less prominent on contraction of sternocleidomastoid, and it is hard in consistency, and it is fixed and immobile. The surface is nodular, and borders are irregular. And trachea is in midline. And bilateral carotid pulsations are felt in normal location, and no other swellings palpable on same side and opposite side of neck. And there is no features of hormonal syndrome like meiosis, anaphthalmos, and hydrosis, and partial ptosis, and no swelling palpable in both the axilla, and no parasternal dermis. Coming to the examination of oral cavity, lip, tongue, buccal mucosa, floor of the mouth, tonsillar pilus, and tonsillar fossa, retromolar trigon, soft palate and hard palate are gingival surface and normal. Teeth are absent in the right lower half of lower jaw, and nicotine stained teeth are present, and there is no enlargement of parotid. Examination of external ear is normal, and the examination of nasal cavity is normal, and the voice is normal, and the examination of other lymph node root, there is no enlargement. Coming to the other systemic examination, respiratory
Just a minute. Similar to the inspection, as I said, palpation, you have to say, I have done palpation from which position?
In sitting position with arms by the side with
Okay. Where will be there? Where will be standing?
standing behind the patient.
Yes, that you have to say. Okay, then only it will be evident that you are examined the patient. Standing behind the patient,
Yes.
starting palpation. These are the findings like that, with a slightly
Yes.
flexor neck. Okay.
Yes.
Then, before going to the other examination, what is the drainage area of the head and neck? Neck swelling, neck lymph nodes. You have said oral cavity, nasal cavity, your anterior nares, you are told, ear, you are told. What else you have to look for? Head and neck region. Inspection, palpation. Face and scalp. Okay.
Okay.
That also includes the drainage area of the cervical group of lymph nodes. Any swelling or you are told know the swelling in the same side or opposite side. Then any swelling, obvious swelling in the scalp area, face region. By inspection, palpation, you have to say no swelling, no such lesion. Okay. You have said no swelling in the parotid area by palpation also.
Yes, sir.
What about thyroid region?
There is no vital, sir. There is no.
Yeah,
Thyroid
that also you can say there is no swelling in the region
Thyroid
of thyroid gland. Okay.
Yes.
And skin changes, you have to say what are skin changes we can appreciate on inspection.
If there is any scars, sinuses, enlarged veins,
Sinuses, fistulas.
fistulas, sir.
Yes.
Enlarged veins.
Over the swelling. Any scars, sinuses, fistulas. And one more sign is platysma sign. What is platysma sign?
There is a if the swelling is large and platysma is
No. The swelling infiltrating the skin or platysma will produce grooving or tethering. It will be prominent at that area. Platysma will be prominent. That indicates what? Skin involved. Okay. Here there is a suspicion of tuberculosis. Okay. If the skin is involved in tuberculosis, what do you call the condition? Skin going for sinuses, discharges, color changes.
colors for diabetes. It's
We heard of scrofloderma. What is scrofloderma?
It's a involvement of skin.
These changes. Skin will be hyperpigmented. Okay. That area with sinuses discharging pus material because there is a history of some intervention in the submandibular region. Okay. Fine. Yes, proceed.
Coming to the examination of other systems, respiratory system, normal vascular blood sound head and no heart sounds. Cardiovascular system, normal heart sounds head and no murmurs. Central nervous system, no focal neurological deficits. Per abdomen, no hepatosplenomegaly and no evidence of free flow. And musculoskeletal system, there is no bony tenderness. Coming to summarizing my case, 64 years, pan sure with a single 7 into 5 centimeters, spineless fixed hard swelling or right level 3 cervical lymph nodal lesion without any primary lesion symptomatically and clinically.
Okay, just go to the oral cavity examination.
Yes.
You have examined only the lip, tongue, buccal mucosa. So, what are the hidden areas of the oral cavity?
Fossa of Rosenmüller.
Have you examined that?
By sorry, examine.
You are not mentioned.
No.
So, how you are examining that area? Also, how do you examine the sinuses? Maxillary sinus. Suppose the maxillary sinus, there is a tumor, what sign you will have? You will have infraorbital region.
Dr. Vamsi, look, this is a very specialized area, right? So if the examiner asks you how will you examine, you say, I will refer the patient. You will take help of a ENT surgeon to complete your examination. So you say that. Don't we all do that in our hospitals? We take the help of someone else. You can't complete everything yourself.
Okay.
So you say that. Simple.
What you have presented here is the examination of the oral cavity, and apart from that, you have to examine the pharynx and the larynx. That is to be done with the ENT surgeons or the endoscopy. Few things which has been missed there in oral cavity. You must know the boundaries of the oral cavity, and before you start examining the oral cavity, you must comment about what is the mouth opening there to the patients. See, is it important to mention about the mouth opening, because some of these patients may have a trismus there. And the other thing which is to be mentioned there, if the patient has any lesion present in the form of leukoplakia, erythroplakia, or the patient have a submucous fibrosis, that is to be commented about. And you have said the patient have teeth, tooth, they are absent there on the right half. So it is important if there any caries which are present there, along with any ulcerations if it is there, because see the patient is edentulous now. So whether the teeth are absent there only on the right side, or it is absent there in other part of the oral cavity also. So it is detailed examination about the teeth is to be mentioned here, apart from any fissure and ulceration if it is there, that is to be mentioned, which is totally missing here. So a pan chewer must have those findings, which must be presented here. Thank you.
You must know where does he keep the pan.
Teeth formula also. What is the teeth formula, normal formula?
2, 1, 2, 3, 7.
So in which, how many teeth are missing and which teeth is missing?
In lower right side lower half of complete to all teeth are removed, sir.
How did he lose them? How did he lose them? Did they fall off on their own, or did he get them removed?
Yes, sir, they are removed, sir. There is tooth are there. They are removed. They are planning for radiotherapy, sir.
So they remove the teeth for radiotherapy.
Yes, sir.
Okay, so you can tell that in the history because you know about it.
Radiotherapy to where? Radiotherapy to the?
It's swelling and towards right half of the neck.
So empirical radiotherapy.
Yes,
Dr. Vamsi, there's an ethical issue in these cases of unknown primaries, because here you have to treat the secondary without treating the primary.
Yes.
Right? So this is how first you have got to go investigate whether, look, there are certain which are clinically the primaries are unknown, but if you look for them using investigations, you can still find them.
Yes, sir.
Right? So CUP is clinically unknown primary, but if you investigate, you can still find the primary. So you have to investigate before we go in for. So how will you proceed now?
So first, I will do to confirm my diagnosis. I will do ultrasound neck, sir. In ultrasound neck, the origin of the swelling.
Ultrasound neck will not confirm your diagnosis.
Swelling, the origin of the swelling, and ultrasound guided biopsy, sir, kinetical aspiration cytology, to confirm whether it is malignant or not. Then I'll proceed with CECT next, sir.
No, hang on. You have to find out whether what type of malignancy. What type of malignancy is there in the neck usually?
Usually 80% it is squamous cell carcinoma.
So you should know whether it's squamous cell or adenocarcinoma.
Adenocarcinoma.
And then you will widen your search.
Yes, sir.
It can be even anaplastic, unclassified, or a de-differentiated carcinoma. It can be poorly differentiated carcinoma. So anything you can get.
Yes,
so depending upon that only, you are further. If it is a squamous cell carcinoma, you are going to focus on those area. Adenocarcinoma, you are going to focus.
Yes.
So you are done an FNAC for this?
Yes, sir. FNAC done.
What was the report?
It was a well-differentiated squamous cell carcinoma, sir.
Okay. Now your next line of investigation proceeded for that. And what is the investigation you have done?
I'll do CECT neck from skull base to root of neck, sir, to rule out the primary origin, sir. If any primary lesion is visible, then it will plan for guided biopsy, sir.
So only CT or whether you will do MRI also?
Now, have you done a pan endoscopy just now? Have you done that? Have you got that done, pan endoscopy?
Yes, sir.
So what does pan endoscopy entail? What do you do in pan endoscopy?
Pan endoscopy will do laryngoscopy, bronchoscopy, and upper GI endoscopy, sir.
And nasopharyngoscopy.
That's it.
And then what do you do then?
If any suspicious lesion is there, then we'll take biopsy from that lesion, sir.
And if you don't find any suspicious lesion, then what do you do?
Then we'll take blind biopsies, but it is not
From where? What is that called? That's called surveillance biopsy.
Surveillance biopsy, sir.
Yeah. So where do you take the biopsies from?
We'll take biopsy from Valdez ring, sir.
No, you don't.
Tonsil and
okay, take it from tonsil bed. What else? Tonsillar bed is one.
Fossa Muller, 5 from Fossa.
3.
Mucosa of the tongue.
Base of tongue, okay. 4.
Base of
lateral wall of pharynx 5 and subglottic larynx 6. So 6 areas you take.
Yes.
See, what is occult primary? What is unknown primary?
Yeah, what's the difference between occult primary and unknown primary? Very good question.
After all the radiological investigations, if the primary is not known, then it is unknown primaries.
No.
Okay. And then what is occult? Then what is occult?
No idea.
So you want to make some correction?
Yes.
Okay.
What is it?
Occult means hidden, right?
Yes.
So if in spite of every investigation you can't find it, it is unknown, right?
Yes.
But if it is hidden and it may show up later on.
Okay.
At primary may show up later on, right? At present,
Yes.
it's not. Why do you think this happens? Why do you think the primary is not being seen now? What could be the causes?
By the time of nodal presentation, the primary tumor may involute or regress.
Okay, very good. It may involute. Second.
And the lymphatic lymph metastasis is more aggressive than the primary.
Okay, very good. If the metastasis is very aggressive before the primary grows, it metastasizes. Or third, what are the other reasons? We don't have the tools to. They are so microscopic that we don't have the tools to pick them up. Okay.
Yes.
Good, very good.
Sometimes you will take a biopsy and will not do you will say a small cutaneous lesion. You will just do excision without doing that excision, and it has gone. Then the secondaries may come. Like you are because curating DNC, you can do a curating and that goes. So you may not get so and immunoblast reaction also, immune escape or immune blast reaction.
Right.
So especially melanomas, it can go for. There's so many other reasons for that.
Okay, can you tell us the tumors which regress on their own? Vamsi. Name of tumors which regress on their own. Tumors which can regress on their own spontaneously.
Related to the ear. Some clue. Any cranial nerve?
Retinoblastoma.
Schwannoma also.
Neuroblastoma. Malignant melanoma. And sometimes nephroblastoma. Okay.
Is it good or bad? No? Suppose the malignancy is spontaneously regressing. Is it good or bad?
Bad, sir.
It shows the immunity is good. That's why it's regressing. Shows the body's immunity is good. That's why it's regressed. Okay. If it doesn't regress, that means the immunity is poor.
Okay.
So please.
Vamsi, I don't know whether it is very clear to you or not, because examiners keep you asking questions. So how you approach to these patients, which is the first investigation, because patient already on FNAC turned out to be a stem cell carcinoma. So you may be suspecting a lesion somewhere in the upper digestive tract. So the first thing, of course, the CECT is to be done to these patients, which not only done for the neck, but you should also include the paranasal sinuses also, because there may be a lesion there in the paranasal sinuses, which can metastasize there to the upper neck. So that is to be done. And apart from that, on the CT, you can also look into the thyroid, exactly the thyroid is normal or not. And then you can have a panendoscopy, which is to be done. What you have said is in the panendoscopy, you have not included what is to be looked into the panendoscopy. You have said the nasophryngoscopy is to be done, the laryngopharyngoscopy is to be done, esophagoscopy is to be done, and the bronchoscopy is to be done. That's all includes the panendoscopy. You should not forget any of them. You have not told them anything about the bronchoscopy. That is to be included as a part of a panendoscopy. And if you get any lesion, then you can do you can biopsy that lesion. If you won't get any lesion, then you can do a surveillance biopsy, what we have discussed about. We have already discussed about what are the reasons from where you can have a biopsy. And then, of course, if you after doing this, you can follow up these patients as it has been said. Thank you.
Also, you will do PET scan this patient.
Roll of PET scan.
PET scan.
Sir, but in PET scan, the false primary is not visible in both panendoscopy and the CECT neck. Then we'll go for PET scan, sir. PET scan of whole body.
The yield of PET and cup is very low. It's something around 40 to 50% only. Suppose your FNAC shows it is undetermined, or you have a anaplastic carcinoma, dedifferentiated. How will you proceed? You are muted. Huh? Please unmute.
Immunohistochemistry marker, sir. I'll do pan-CK marker.
Dr. Jalan has asked you if you have a poorly differentiated tumor there on histology, what you will do.
You said you will do immunocytochemistry, no? Immunochemistry.
Yes, sir.
So what you will do? What?
Pan-cytokeratin receptor. If it is positive, then
What do you mean by pan-cytokeratin?
the cytokeratin is most common. The origin of tumor from epithelial cell. Squamous epithelium.
So in a columnar epithelial adenocarcinoma, cytokeratin will not be there. Pan-cytokeratin to say which is a carcinoma. So you have to then again go to the cytokeratin 5 and 7 for the squamous, and 7 and 5 and 6 and 7 and 20 for the columnar carcinoma. So that is so it can be carcinoma, it can be lymphoma, it can be melanoma, it can be sarcoma. So each for that, and each histochemistry you have to do multiple histochemistries.
Yes.
Vamsi, can you do an open biopsy or do you have to do an FNAC here? Any reason? Can you do an open biopsy of the lymph nodes?
If we plan for open biopsy, then it will include in the incision sites.
No, not really. That's nothing to do with sarcomas. Here you can't do it because it distorts the plane. So if you have to, and then it causes faster spread of the malignancy to the next level of lymph nodes.
Other level.
Right. So that's what we should avoid.
See, what Dr. Rajiv sir want to know exactly if it can turn out to be a squamous cell carcinoma, can you do a biopsy here in these patients. That is the excisional biopsy or incisional biopsy. That is not to be done in these patients. So it's all because you already have a diagnosis of squamous cell carcinoma. And when you're operating these patients, when you're doing a biopsy, you're distorting the plane, and the chances of recurrence also becomes difficult even you are changing the lymphatic drainage of the area. So it is important that if you're planning to have excision, that is to be included with the neck dissection rather than doing a excisional or incisional biopsy in these patients. That not to be done if it is a squamous cell carcinoma. Of course, if you won't have a diagnosis in these patients with FNAC, better to have a core biopsy, which is to be done to these patients to have a diagnosis, where you can have an IC done to have a diagnosis. And once you have a diagnosis, then you can plan your treatment accordingly. If it turn out to be a lymphoma, even in these patients, you can treat the patient accordingly. Thank you.
Right. Excellently explained.
What is the staging for this?
It is N3A, sir.
So what is the plan you have? So you have done a biopsies from the CT biopsy? Have you done the CT biopsy?
No, sir. No, sir.
Okay.
What is the T
straight
stage?
away.
TX or T0? Yes.
TX, sir.
TX. What is T0?
TX's primary tumor is not identified.
Okay.
There is no evidence of primary.
So here you have not identified the primary, no?
We're not told T stage. That's why I'm asking.
Okay.
Okay. T0.
So it's a
M0.
Origin from squamous cell carcinoma. You have a N3 node. So how you are going to proceed?
First, I will give chemo radiotherapy, followed by downgrade the tumor. Then I will do radical neck dissection.
What do you mean by chemoradiotherapy?
First, we will give chemotherapy with low dose chemotherapy, sir. That will sensitize the cells from G0 to G1, sir. These cells will take up the radioactive dose, sir. That will, radiotherapy will be effective and will be given with chemotherapy.
So after radiotherapy?
Then you will assess the size of the tumor by doing
chemoradiation starts only with starting with the chemotherapy, or it ending also with chemotherapy?
Ending with chemotherapy.
It's a radiation is sandwich. You have a chemotherapy, then again you have to give a chemotherapy for that. So you have done a chemoradiation or radiation, then you are expecting the tumor to regress.
Yes, sir.
So do you think at N3 tumor at this stage is inoperable?
Inoperable.
Node is fixed, I think. Yes. Is it fixed node or mobile node? You said fixed node.
Okay, it's a fixed node. Okay, fine. So then what if after radiotherapy, and what surgery you want to do?
I will do radical neck dissection.
So curative resection is your intent. Without knowing the primary, are you planning for a curative resection or palliative resection?
Palliative resection, sir.
So you give chemo radio first, get a PET CT done, see whether it's resectable. If it's resectable, going for surgery. If not, again give chemo radio again. Okay, that's the thing.
Okay.
What is RECIST criteria? How will you know that the tumor is responding to your chemotherapy?
Tumor size, decreasing tumor size, and
so there are 4 components to it: complete response, partial response, stable disease, progressive disease. Okay, you'll have to read about it. Right, you must know the RECIST criteria. So
will you do for anything for opposite neck?
So prophylactic radiotherapy will be given to the opposite side.
What do you want to give prophylactic to the node there?
Because the node size it is in N3C, N3A, sir. I'll expect some lymph nodes in opposite side. Sir. There may be chance of bilateral.
So what carcinomas are more prone to go for a bilateral lymph node?
Carcinoma from tip of the tongue and nasopharynx.
And the lip. So here you are not having it. You are seeing there is nothing is there. You are not deceived.
Yes.
Suppose we want to do neck dissection, what type of neck dissection will do? Radical or modified radical or functional or selective? Which one will do? Choose. In this patient. What is the biopsy? Biopsy is squamous cell carcinoma. Okay.
Squamous cell.
Which one you will choose?
Modified radical.
Modified radical. You want to do, you have to do
which type?
radical only.
Which type? Type 1, 2, 3. Which modified radical you are going?
Type 3.
How it differs from functional neck node dissection? Modified type 3 neck node dissection and functional neck node dissection, what is the difference?
In functional neck dissection, we will preserve final axillary nerve and sternocleidomastoid mastoid and the internal jugular veins.
Type 3 modified radical also, you preserve all the three structure.
Okay.
So is both are same?
Both are same.
No, it is not same. What are the lymph node groups you removed in the modified radical?
Level 1 to level 5, sir.
In the functional neck node dissection? You won't remove the level 1.
Okay.
So don't mix that. Functional is separate. It is only for adenocarcinoma, only for the there we are not only preserving, but we are also only a selected lymph node group only. So the word or the ideal way to examine is a comprehensive neck node dissection. So then depending upon that, you can say it's a comprehensive neck node dissection, which includes all these things. Can you do the bilateral neck node dissection?
If opposite side lymph nodes are palpable or
so what precautions you will take when the bilateral lymph node dissection is done?
No?
When you do the bilateral neck node dissection or radical neck node dissection, bilateral or modified radical, and what are the challenges you will have?
Preserving at least one side of internal jugular veins.
Then you will not call it as a radical, no? So why do you want to preserve one side?
To prevent cerebral edema.
So suppose you need to sacrifice both, then you should take measures to prevent the cerebral edema, either by doing keeping the patient in the upright position, not putting a compressive bandages. So that can help you with that.
Yes.
How long it will take to settle the cerebral edema? Suppose you are doing one-sided ligation of internal jugular vein. Patient will develop usually cerebral edema to some extent. How long it will settle? How many days? In 1 week or 10 days, it will settle. Okay. What the type of incision you will prefer? You said you are giving radiotherapy followed by neck dissection in this patient. Suppose you are giving radiotherapy, what type of incision you choose? What are the various incisions for neck dissection? What is the commonly used? What is the commonly used ideal incision? Modified Schobinger incision. Okay. Here, you are giving radiotherapy. What is the problem with the radiotherapy to the skin? So, there is a chance of flap necrosis. To prevent that, what type of incision you can choose? McPhee incision, parallel incision. Okay. That we can choose. When you choose apron incision? Apron incision is starting from the mastoid, coming to the suprasternal notch, again going to the mastoid. This incision is chosen in which condition? Carcinoma of larynx with the neck dissection. So according to the neck problem, what are the groups of node, what are the type of primary, you have to choose the incisions. Okay. What are the complications of neck dissection? Complications.
Hemorrhage from the major vessels and injury to the cervical sympathetic chain, injury to the thoracic duct. There is injury to the cranial nerves of 9 and 10. There is injury to larynx and trachea.
No. What is the posterior extent of your neck dissection? Posterior extent. Which fascia you have to preserve?
Prevertebral fascia.
Yeah. When you go beyond that only, splenic nerve injury, all this happens. Okay. What are other complications? Apart from local injuries, what are other complications?
Flap necrosis.
Flap necrosis. But what is the point where flap necrosis is common? Which point? Junction of all the three incisions, meeting point. Okay. So you have to choose. It will not come in the point of division of the carotid vessels. That's why the Schobinger, modified Schobinger incision is chosen. Okay. What are other complications? What is the problem with the left side and neck dissection? Compared to the right, what is the complication in the left side and neck dissection? Thoracic duct injury.
Injury to thoracic duct injury.
What will happen? Suppose you have an injured thoracic duct, what will happen?
There is a leak of
how it look like? How when it is leaking, and how it look like? It's a watery, anything else it will be. What will be the color of the chyle? Oh, it is a milky white.
White.
How will you? When will you interfere, or when will you leave it alone? What is high output fistula? What is low output fistula?
More than 300 ml.
More than 500 ml. First, you must be avoid the if you have a drain which is giving the suction drain, that you should remove. And as long as you keep the suction drain, it will continue to go. You have to remove that. Keep the patient head and elevated. Avoid carbohydrate food and see that whether it is decreasing. If it is not decreasing, you have to again go back. Either a ligature or mass suturing you have to do.
Okay.
This carotid blowout followed by neck dissection. How will you prevent the carotid blowout? Suppose you are doing radical neck dissection. There is no structure. Sternum muscle cover like that. Neck is very exposed. What muscle you cover? For femoral vessel inguinal dissection, what muscle you cover? Inguinal neck dissection. Sartorius muscle.
See, ilioinguinal.
Okay. Similarly here, neck dissection, to cover the carotid vessel, which muscle you choose? Levator scapulae. Okay. That muscle may be bring down over the carotid vessel.
Okay.
Can I well, sir?
Okay, I think can we call it a day now?
Yeah. Vamsi, do you have any question?
No, sir. Thank you.
You've done well, Vamsi. Done well.
Thank you. Both the candidates has done very well. Sir, Puneet, sir, you can give your final opinion, sir. Dr. Puneet, sir.
Yeah, thank you, sir. I was there with the other things. Yeah.
You can give a final comments and then
You can go ahead, sir.
He's busy somewhere.
Okay. So we thank both Professor Puneet, Professor Saravanan sir from Madurai and for participation. Both the candidates you have done really well. Thank you very much because the level of questions are a little high, but still you were able to answer most of the questions.
And both the cases were very difficult. Both the cases were very difficult. Very difficult cases.
You need to have the broad view of looking into the case because this is one area where there is no clinical finding much. It is only a not. So most the questions will be more on a question how you are examining, how you are approaching will be there whenever you have a unknown primary case. So both of you are done very well, and thank you very much for all the. Madam Ramani, madam, you are back. Your student has done well.
Good evening, sir. Yes, sir. Thank you, sir. Thank you for giving us the opportunity, sir. He is actually little taken back by your presence, and otherwise he's a good student, sir. Thank you very much.
He is very good. We could understand that he's good.
He is a little slow, but we are very confidently he was answering most of the questions, so it is good.
But we also learned so much, sir.
Professor like Ramani is teaching them, and they will be all happy.
Very much. Bye. Thank you.
Thank you. Nice to. Can I sir, you come back?
Sorry, sir.
You are busy today.
Any other input from the faculty? Before we finish, I have something to share with the faculty. There have been some requests from the NHS group from the UK to do a competence assessment of our teaching program. So I wanted to take your inputs. Should we allow them to be part of us assessing our standard of teaching? Or any one of you having any reservations?
No, I think
anyway, I thought of communicating to you in person, but then this is a message from the NHS team because I think few of them have been regularly watching our program. So they've requested this. I would request all the faculty to kindly think about it. Maybe in a week's time, we will have a quick meeting over Zoom and take a decision about this.
External evaluation is always.
So, Kanna sir,
is not
Rajiv sir and others maybe think about it and we can discuss over a Zoom meeting regarding this issue.
Sure.
Then we will take it further, sir.
Definitely.
Faculty, Puneet sir and Saravanan sir and Ravak sir could not join today. I guess he has some issues. Thank you, Ramani ma'am, and for contributing this. And thank you for giving us a faculty. Kana, Vamsi, do you like to ask questions to the faculty?
No, sir. I am very thankful to present the case in this platform. I am very thankful to Professor Ramani, my sorry, Padmashri madam.
Good luck to you. Thank you very much, faculty, sir. Thank you, Karnakaran sir.
Thank you,
sir.
Thank you, sir.
Hi, sir.
Thank you, sir. Thank you all, sir.
All the faculties.
Sir and
candidates.
thank you
All the
very
best
much.
for the candidates.
Thank you.
Thank you, sir. Thank you all, sir.